Good evening, everybody. This is Balaji from MCure Pharmaceuticals, welcoming you to this evening's webinar. For those of you who are joining us from India and the nearby countries, very good evening to you. And for those of you who are joining from other parts of the world, wishing you a very happy Friday. It's been a tradition that MCure presents these updates from IAS on every year, and so also this year we are happy to have our eminent speaker, Dr. Sanjay Pujari, present his slides. More interestingly, his interpretations of the scientific details that was discussed in the conference. Before also on this webinar is our Director Medical Affairs, Dr. Rohan Gurjar, who has a doctorate in pharmacology from the University of Liverpool. And prior to that, he did his pharmacology from MSc Pharmacology from the Northeastern University, Boston. Dr. Rohan has done work briefly with a National AIDS Research Institute in India on a phase 2 trial comparing nevirapine with efavirenz in patients co-infected with HIV and TB. And amongst his other projects, he has done work on pharmacokinetics and pharmacogenetics on antiretroviral drugs in phase 3 study, which compared a 2-drug regimen of darunavir, ritonavir plus raltegravir with darunavir, ritonavir plus tenofovir emtricitabine. He is currently a part of the clinical development team and has successfully launched the SARS-CoV-2 vaccine, Gemcovac 19, along with the Omicron specific variant developed by Genova Biopharmaceuticals, the biopharmaceuticals arm of MCure. So over to Dr. Gurjar, Dr. Rohan to introduce Dr. Sanjay.
Thank you, sir. I'm sure Dr. Pujari needs no introduction. You've all come here to listen to him. Nonetheless, I'll speak a few sentences to set the tone. Dr. Pujari has done his MBBS and MD in internal medicine. He's a fellow of Infectious Disease Society of America. He's also the director and chief consultant of Institute of Infectious Disease in Pune, and also a consultant in HIV medicine and infectious disease in Pune Hospital Research Center. He is the principal investigator of Treat Asia, that's therapeutics, research, education in AIDS treatment at Pune, and the STAR study, which is strategic timing of antiretroviral treatment, also in Pune. If you follow him on ResearchGate or any other platforms, you'll always see in a couple of months he keeps publishing. You see a new paper coming out, and there are 100 publications that he's published. And of course, he has attended various symposiums across the globe for HIV. Before I bring Dr. Pujari on, just a few housekeeping rules. During the presentation, please post your questions on the Q&A section or the chat. I will be taking those questions, and at the end of Dr. Pujari's presentation, I'll make sure I try to cover all the questions that you've posted.
Okay, can I share my content?
Yes, sir.
Sir, can I request to switch on your video as well?
Yeah, I will.
Yes, sir.
Yeah, just a moment. Okay, shall I start? Thank you for this opportunity. We will be discussing some of the interesting presentations at IAS, which was held at Brisbane, and looking at some of the translational aspects which may help us to manage our HIV patients in clinical practice. So as you can see here, this is the statistics of the abstracts, there were some 3,800 abstracts which were submitted, out of which only 38% got finally accepted. So quite a difficult task to go through all the abstracts. Nevertheless, I have tried to summarize this into 3 categories of antiretroviral therapy, comorbidities, and some interesting aspect on prevention of HIV. So as far as antiretroviral therapy is concerned, there is a lot of interest on minimizing antiretroviral therapy exposure in terms of 2-drug treatment. And the week 196 results of the TANGO study were presented at the meeting. As you all may remember, TANGO tried to randomize patients who are virologically suppressed to a 2-drug regimen of DTG3TC or continuing the TAF-based regimen. And at 148 weeks, those on TAF-based regimen were transitioned at the late switch and categorized as late switch to DTG3TC, and this looked at week 196 analysis. And as you can see here, whether it is early switch or late switch, and early switch day 1 to week 196, people who continued to be on 2-drug regimen for the entire 196 weeks. If you look at the primary outcome of proportion of individuals with more than 50 copies, there is actually hardly any difference there, as well as the proportion of individuals in secondary objectives of achieving a viral load less than 50 copies, also demonstrating that whether early or late switch or whether early switch to 1 to 196, the proportion is quite similar. And if you look at subgroup analysis, both for the early switch as well as the late switch groups, based on CD4 counts, baseline third agent class from which they were switched to DTG3TC, whether it's an NRTI, INSTI, or PI-based as core drugs, and the stage of HIV disease, there is no difference in the proportion of individuals. And is similarly seen across all these subgroups. So in terms of some of the clinical thoughts of 2-drug regimen, it seems like the data for using DTG3TC as one of the options for 2-drug regimen for maintenance of virologically suppressed patients has a durable efficacy and is quite safe. And I think it should be incorporated in the WHO guidelines as well. As and when it evolves, it's already incorporated in some of the high income setting guidelines. And of course, it should be considered to save costs, toxicities associated with either TDF, TAF, abacavir, which you can avoid when we use this, and reduce the lifetime ARV exposure. Again, focusing on DTG3TC, expanding this to look at whether this can be used in a younger population. And this is actually a naive study in which adolescents between 12 to 18 years and weighing more than 25 kg, a single arm study where they were initiated on DTG3TC. They had some PK data as well. But this looked at extended week 90 endpoint of proportion of adolescents with virologic suppression. And as you can see here in the intention to treat either E analysis or a sensitivity population, the proportion of individuals, adolescents achieving a viral load less than 50 copies is quite great. About 88% of adolescents achieved undetectable viral load at the end of 96 weeks. So in terms of the role of DTG3TC, there seems to be an expanding role for this beyond the adult population in ARV-naive adolescents as well. It's particularly significant because we know adolescents are a challenging group to ensure adherence to antiretroviral treatment. So having drugs which basically reduce the cumulative exposure of total 3-drug regimen can be can be avoided. And finally, the impact of TDF or TAF during growth phase, particularly on bone-related issues, may be mitigated by this approach. We all know that the Tango study or the Salsa study recruited individuals with no historical evidence of M184V or a history of 3TC resistance in the past prior to switching them to DTG 3TC. But this study looked at, without doing a baseline resistance testing, adults randomized to DTG 3TC. This was an open label study or TLD based regimen, and analyzed week 48. Incidentally, they had blinded genotypic resistance testing at baseline, and they will be unblinding the genotypic resistance test reports at week 48. The conference saw a presentation for week 24 data. And again, as you see here, there is no difference in the proportion of individuals achieving virologic suppression between TLD versus DTG 3TC. And the treatment difference has a non-inferiority margin of 7.9. And this is a set non-inferiority margin. So it achieved non-inferiority. So the clinical implications of this is, even without baseline resistance testing, because transmitted integrase resistance is practically unknown in many parts of particularly lower and middle income countries, DTG 3TC seems to be an effective regimen for ARV naive patients. But of course, we need to wait for 48 weeks when their final results, whether this is durable. And also we need to be waiting for some data on the GRT, the resistance testing they performed, both blinded and unblinded. That would be interesting to look at in future. Nevertheless, it seems to be that DTG-CTC is an interesting option across various population categories, including those where you do not perform baseline resistance testing. Finally, it was also interesting to look at extended data from the SOLAR 3D study, which looked at switching to DTG-3TC, a single-arm study, with prior virologic failure and a historical 184V. So these were treatment-experienced patients on stable 3 or 4 drug ART with an HIV RNA less than 200 copies. And they had prior historic 184V and a history of virologic failure to one of their previous regimens, with a viral load more than 200 copies. And they were stratified based on whether they had historical 184V or not. And then they analyzed looking at the efficacy. So as you can look at the population which was recruited. These individuals had a long-standing HIV diagnosis, 25 years, ART duration of 22 years. Previous ART regimens, median was 7 previous ARV regimens exposure. And finally, duration of HIV suppression of almost 10 years. And it's quite surprising that though the numbers are small, 50-50 in each group with 184V and no 184V, what you can see here is the proportion of individuals achieving viral load. More than less than 50 copies is quite similar, and the virologic failure rates are also no different. So the clinical implications is that perhaps DTG-3TC seems to be useful as a maintenance strategy, even in the presence of an historical 184V. But there are a lot of caveats in this study before we can translate it into clinical practice. One obvious is that 100 patients were studied and 50 had 184VI, evidence for 184VI. So though this data is for 96 weeks, we need to have longer follow-up data to see whether this holds true. The other important aspect looks like historical 3TC resistance may not matter because these are perhaps being fizzled out from the reservoir as the duration of virologic suppression increases. So maybe that is one theory where you don't see the impact of 3TC resistant mutations, which may have fizzled out over a long period of time. But in clinical practice, unless and until there is an absolute contraindication for a third drug like TDF or TAF or abacavir, carefully weighing the risks, maybe a population with careful monitoring, we may look at trying to use this regimen. The other interesting aspect is patients, as we know, globally are being transitioned, particularly in lower middle income settings, to TLD-based regimens from TLE. And the important aspect is when patients come to us with the non-adherence or with the virologic failures, loss to follow-up, etc. In that situation, when they revisit your clinic, do we start the same regimen? What are the resuppression rates? So in the advanced study, which you all may remember, was a randomized trial looking at TAF FTC-DTG versus TDF FTC-DTG and a TLE-based regimen in ARV-naive populations. They identified individuals with a viral load more than 1,000 copies and then provided them enhanced adherence counseling, and then they measured the rates of virologic suppression at weeks 24 and 48. So this is the original advance results for these patients. As you see here, initial suppression rates were non-inferior between the DTG arm and efavirenz arm, and virologic failure rates were also similar. But when you, after virologic failure, reinitiate the same regimen, so you reinitiate the dolutegravir based regimen or reinitiate the efavirenz based regimen, you can see here a dramatic difference in the proportion of individuals who suppress after reinitiation with TLD as compared to those who reinitiate with TLE, perhaps suggesting that, reinitiating with TLD in individuals with virologic failure with enhanced adherence counseling is an effective option rather than switching them onto a boosted PI darunavir based regimen. The reason for that is this summary of dolutegravir mutations on virologic failure in various studies. So if you see here in naive patients, these are all the trials in naive patients, and these are the virologic failures having genotypes. And you can see here there is no dolutegravir resistance reported in naive patients. In the maintenance studies, the Tango, Salsa, 2SD, etc., again, few genotypes with virologic failure, but no mutations in this for the integrase. And finally, when you switch for failure, in the second line, we have the Nadia study, which actually showed a signal for DTG resistance happening when somebody switches from TLE to dolutegravir-based regimen in second line, though further analysis of this study is awaited. So it's extremely rare to have integrase mutations who can reinitiate the same integrase drug to re-achieve virologic suppression. So as I mentioned, dolutegravir resistance at virological failure of first line is practically not reported. And that is why resuppression with the same regimen with enhanced adherence counseling will help to re-achieve virologic suppression. In that case, there is no need to switch to a boosted PI-based regimen unless you have access to resistance testing to integrase and document integrase resistance. This can happen maybe in second line TLD. For efavirenz-based regimens, however, it's better to switch because the risk of efavirenz resistance because of its low genetic barrier to resistance is very high. And that is the reason why it's better to switch to a TLD-based regimen. But then again, from the Nadia trial, you have some signal for DTG resistance emerging. If you're worried about it, you can perhaps think of moving to a darunavir-ritonavir-based regimen as an option. Finally, this segment I'll end by talking about the Geneva patient who basically a patient with proposed cure after stem cell transplant with a wild type CCR5. All the previous cures were with the delta 32 CCR5 stem cell mutations. But here is a patient who had a wild type CCR5 and was engrafted because of a sarcoma. This patient was virologically suppressed for a long period of time. And then there was a performance of stem cell transplant for this individual. And subsequently, after 2021 November, this patient stopped ART. And for 20 months, this patient is having undetectable viral load. Apart from that, this patient has not detected viral load in very ultra sensitive viral loads. The integrated HIV-1 DNA in the peripheral blood mononucleus, PBMCs is also negligible or not detected. HIV DNA in CD4 cells not detected, and so is true for bone marrow. So this basically is the first proposed cure with the wild type CCR5 stem cell transplant. There is a debate going on about what really worked in terms of achieving this remission in this patient, whether it was the graft versus host disease or immunosuppression. 2 cycles of ruxolitinib was given to this patient to manage the graft versus host disease, and there is some evidence to suggest that this drug is able to reduce HIV reservoirs. But the authors also say that we need longer term data to confirm this, and HIV may still lurk in some anatomical and cellular sanctuaries. There is a lot of information on comorbidities which was presented at the conference. This is important because, as we know, as our patients come to our clinic, they are coming with a lot of comorbidity issues, particularly the non-communicable diseases. This was not presented at the meeting, but was published simultaneously in the Lancet HIV. This is a phase 2 study looking at using TLD OD versus TLD with an additional dose of dolutegravir with concomitant rifampicin in management of HIV TB, and what they found was no difference in virologic suppression rates. As we know, we tend to double the dose of dolutegravir when we use it with concomitant rifampicin. However, in this phase 2 study, they couldn't find any difference in the rates of virologic suppression. So there is emerging evidence for using dolutegravir once daily with rifampicin. Apart from this phase 2 study, there are 2 or 3 observational cohort studies from Africa where they show good virologic suppression with using OD TLD with rifampicin. The debate really is whether we need a phase 3 trial to confirm these findings, or whether we can just roll it out and do implementation research in the real world to assess the efficacy of this. So this is an interesting practice-changing kind of study, which may give us confidence of using TLD-OD with rifampicin. The other issue when managing HIV and TB together is when you initiate, since everybody is moving to an integrase-based regimen, because of the rapid fall in the viral load after initiating INSTIs, whether this leads to a higher risk of IRIS. So there was an interesting study presented, which was from the REFLECT-2 study, which randomized HIV co-TB infected patients to efavirenz and raltegravir 400 milligram BID. And basically they looked at what is a percentage of IRIS between these 2 groups. So as you see here, in terms of being free of IRIS, there is no difference in these 2 populations between these 2 regimens. But what really made a difference was a low CD4 count, a high viral load, more than 500,000 copies, and having extrapulmonary and disseminated disease, rather than which core drug you are having, whether it's an integrase or an efavirenz. That is a risk factor for developing TB IRIS. So it seems that rapid fall in the viral load may not be a risk factor for developing TB IRIS. While traditional risk factors like low CD4 count and having extrapulmonary TB and having a very high viral load of more than 500,000 copies at ART initiation may be important risk factors. But remember, there is this PRED-IRIS study from South Africa, which demonstrated that if you give steroids concomitantly while initiating antiretroviral therapy in HIV with TB, and when they have a CD4 of 100, reduces the incidence of TB IRIS as well as the need for management of TB IRIS procedures. So that is something which should be important and should be uniformly done in clinical practice. The other interesting aspect is this for TPT, there is a newer regimen, short course like 1 month of daily INH rifapentin or 3 months of weekly INH rifapentin. We didn't have much data about whether we can safely use this with the TLD. Now, this is a study from Thailand. It's actually a randomized trial comparing these two regimens. Initially, patients were on an efavirenz-based regimen, and then subsequently a significant proportion of patients translated were switched to or initiated a TLD-based regimen. And as you see here, the virologic suppression rate is no different across these groups, whether rifapentin is used with efavirenz either once 1 month or 3 month regimen, and as well as dolutegravir. So this study is something which gives us confidence in terms of using short course rifapentin based TB prevention treatment along with TLD. It's safe and it was safe as well, and of course efficacy data is shown. The problem in India is rifapentin is not available in the private market, and it's very important for us to get this molecule for shortening the duration of TB preventive treatment, as well as some data available for use of it replacing the rifampicin and the ethambutol, the rifapentin moxifloxacin regimen for drug-sensitive pulmonary TB management. As far as HIV-HBV co-infection study, ALIGN study investigators again presented extended data of 96 weeks HIV-HBV co-infected individuals randomized to TAF-FTC bictegravir versus TLD, and looking at both HIV as well as HBV DNA outcomes. And as you see here, no difference between these two arms, both for HIV outcomes as well as HBV DNA outcomes. But in terms of HBe antigen loss and HBe antigen seroconversion, it seems that TAF-FTC bictegravir seem to be performing better as compared to TLD for both these anti-HBV markers, as well as for HBsAg loss and HBsAg seroconversion. TAF-FTC bictegravir seem to be performing a little better than the TLD-based regimen. But at this point of time, doesn't matter whether you use TAF or TDF for managing HIV, HBV co-infected patients. If you're worried about markers of anti-HBV activity, maybe TAF-FTC bictegravir seems to be a decent option. But of course, the trade-offs is going to be choosing between TAF and TDF, the toxicity of weight gain with the TAF versus renal and bone toxicity with the TDF. The other interesting study looked at the risk of severe COVID-19 amongst hospitalized patients who are HIV positive, and the WHO's global clinical platform presented some data on this, where there are more than 800,000 hospitalized individuals with COVID. And in this analysis, they looked at people living with HIV admitted to hospitals with COVID-19. And they looked across various variants, the time frame of each variant defined as more than 90% cases occurring during that time frame to be labeled as occurring due to that variant. The variables they collected apart from demographics were HIV status, medication, CD4 counts, etc. And what you can see here is, as compared to HIV negative across variant waves, HIV infected individuals seems to have a higher mortality, even in the Omicron phase. Of course, the impact of vaccine dramatically reduces the risk of mortality. But in adjusted analysis, you can see here that severe critical COVID at hospital admission, the risk for mortality is higher across wave. Even when we call Omicron has variant to be a milder variant, still HIV infected individuals as compared to HIV positive individuals compared to HIV negative have a higher risk of mortality. The major risk factor is a low CD4 count of less than 200, which increases the risk of this mortality. So the implications of this is for booster and annual vaccine policy for your people living with HIV, and perhaps a variant specific or a bivalent vaccine, etc., that needs to be studied as well as implemented. We all are well aware about the association of weight gain with the integrase inhibitors. So something had to be done about it. And people have started looking at trying to switch away from integrase inhibitors to see if whether you can regain your excess weight back down to your normal weight. So in this virologically suppressed individuals, more than 10% with more than 10% weight gain on an INSTI-based regimen randomized to the cobicistat darunavir versus continuing the INSTI-TAF FTC at week 24 in the DEFINE study, looked at whether weight can be regained, the weight gain can be lost after switching away from integrase inhibitors. And what you can see here in this graph across up to week 24, no difference in the percent change from baseline in weight. And that gives us a signal that perhaps shifting away from integrase inhibitor may not really help to regain your original weight. And the same is true across DEXA, whether it's total fat mass, lean body mass, and total mass pre and post. In these two regimens, you see no difference happening in these masses. So it looks like INSTI-based weight gain may not be reversible with ARV switch, but however, this is a short study, 24 weeks. We need to monitor it for a longer period of time. The second issue is, of course, they continue to use TAF. So we know TAF may be associated with weight gain, but TDF may be associated with weight suppressive effect. So it would be interesting to look at TDF shifting to TDF-based regimens, or maybe rather than PI looking at efavirenz, because that is also something which is associated with the weight loss. But however, in clinical practice, you should remember that this is a heterogeneous problem. Not everybody gains weight. About 20-25% people would gain clinically significant weight. And there are other strategies being pursued to improve the weight gain, and that is one study presented was a retrospective cohort. I didn't present that data here, of using the GLP-1 RA drug semaglutide, which caused a significant weight loss in HIV infected individuals with diabetes and weight gain versus HIV negative individuals with diabetes. So that would be something which is interesting to look at in future. I think the major comorbidity newsmaker of the conference has been obviously the REPRIVE trial, in which individuals on antiretroviral treatment with low to moderate cardiovascular risk were randomized to pitavastatin versus placebo. And this trial had a median duration of follow-up of 5.1 years with a hard clinical endpoint of major adverse cardiac events. And the DSMB closed this trial early for efficacy. The data clearly shows that with primary MACE events, there was a 35% reduction in the risk as compared to placebo. And when you look at composite first MACE or death, there was 21% reduction versus placebo. And when you adjust it, this benefit continued to be beneficial even when you adjust for ASCVD risk score at baseline, or for other multiple factors like age, race, smoking, hypertension, LDL cholesterol, etc., showing an independent effect apart from the LDL cholesterol lowering effect of pitavastatin in reducing cardiovascular events. And this is obviously showing you the LDL cholesterol decline, which happens with pitavastatin in the yellow here, as compared to no difference in the LDL cholesterol in the placebo arm. So the clinical implications of this study are enormous. In the first thing which we start thinking is whether we should be putting all our ART patients with low to moderate cardiovascular risk on a statin along with ART. And is it really ready for translation into practice? I think perhaps it may be yes. This was a global trial, and this included all regions of the world. So it's not that only people living with HIV from the higher income settings were recruited into this side. The second thing is we need to look at for the Indian population, at least the accuracy of the ASCVD risk score for predicting cardiac events. The third important aspect is incident diabetes, which happens with long-term use of statins. And particularly this is significant because I will present you some data about incident diabetes occurring with integrase use. Does it hold true for all statins? Perhaps yes. And this is because the effects are beyond the LDL reduction, what is usually called as the pleiotropic effect of statins. And the number needed to treat is not very harmful in that sense, because it's 106 for treating hypertension. It is 80 to 60 for aspirin that you use in prevention of cardiac events. It's 300, so it's much lower than aspirin for this population. So in that sense, I think this is an interesting study, and we will await further discussions on this study to translate this into clinical practice. The other issue was about diabetes risk with the integrase inhibitors. The response study is a cohort study from Europe and Australia. Again, this is predominantly higher income settings with 30,000 people living with HIV in follow-up, and they collect all clinical data annually. So what they looked at is the incident diabetes across 3 regimens, and as you see here, the incident diabetes probability is higher in the integrase as compared to boosted PI or NNRTI, though you have to look at the probability here. It's quite a low in terms of absolute probability, but still there is a signal that integrase inhibitor may be associated with incident diabetes. And this is a graph which shows you that that association may be significantly explained by BMI. As the BMI increases, the integrase inhibitor incident diabetes increases, and this is the incidence per 1,000 years of follow-up. So it's about 2.53 per 1,000 years of follow-up, and with no INSTI use as well as with BMI. But still there is a gap between these two. So it's not entirely explained by BMI. Maybe there are some other issues which are associated with hyperglycemia with integrase inhibitors. So there is some signal there. We need more data from lower and middle income settings. This is observational study, so that is always having problems with residual confounding and sometimes channeling bias. It is, as I mentioned, only partially explained by increasing BMI. And there may be a trigger for doing mechanistic studies to look at whether integrase inhibitor increase the risk of diabetes. The other issue is risk of hypertension. And again, this looked at 2 trials, the NAMSAL and the ADVANCE trial. And in the NAMSAL's trial, as you see, a systolic BP in the integrase inhibitor arm increased as compared to the efavirenz 400 milligram arms. And the proportion of individual with systolic more than 140 and a diastolic more than 90 was also higher, as up to 192 weeks in the integrase arm as compared to the efavirenz arm. In terms of grades of hypertension, you can see here in the integrase arms, the proportion of individuals with grade 1, 2, and 3 hypertension is higher than individuals on an efavirenz-based regimen. Treatment emergent hypertension in the ADVANCE study also demonstrated new hypertension more in the TAF FTC DTG arm and TDF FTC DTG arm as compared to the efavirenz arm. And this difference between the TAF DTG arm and TLE arm was clinically for statistically significant. But in ADVANCE, they were aggressively managing this. So all of these patients were put on antihypertensive treatment. So again, there is some signal that there may be emergent hypertension associated with the INSTI use. Again, remember, these are, when you look at absolute numbers, they're not very great. When you look at relative numbers, they seem to look great. There are a lot of caveats associated with this. Can it be associated with raised BMI response? The observational study also presented some data on this, suggested that this was associated with the BMI. But for clinical practice, I think it's very important to efficiently monitor and treat hypertension when identified. We all know that bictegravir-based regimens are not recommended in pregnancy because of PK issues. But this study looked at, I think, 20 women living with HIV who were pregnant, measuring AUC of bictegravir. And as expected, you see week 12, second trimester and third trimester AUC much lower than postpartum AUC of bictegravir week 6 and week 12. But remember, this is above the IQ1 of bictegravir concentration for inhibition of the virus. So perhaps there may be a role for use of bictegravir in pregnancy as well. But in this study, the caveat major was all women were already virologically suppressed, and they were switched to bictegravir-based regimen, and then virologic suppression was ensured. No women had virologic failure in this study, and no perinatal transmission occurred. So rather than being so more data maybe for clinical efficacy need to be looked at when you initiate a bictegravir-based regimen in pregnancy, though the PK looks promising. And finally, data from perinatal outcomes, looking at different ARV regimens. This is a systematic meta-analysis. And as you see here, when you compare with NNRTI versus PI, the risk of small for gestational age or very small for gestational age is significantly higher with the boosted PI as compared to NNRTI. It looks like INSTI-based ART are not associated with adverse perinatal outcomes, and boosted PIs, particularly lopinavir ritonavir, is associated with worse perinatal outcome when it is compared with NNRTI with the small for gestational age or very small for gestational age outcomes. So anyway, nowadays we don't use boosted protease inhibitor in pregnancy, so this should be of little concern in clinical practice. Finally, let me end by showing you a very important prevention issue. This was the WHO policy brief, which came out of systematic review published in, I think, Lancet Infectious Disease or Lancet, which looked at a review of HIV sexual transmission with viral loads. And what they found was 3 categories. So WHO now classifies viral load into 3 categories. Undetectable is where there is no measurable virus, there is 0 risk of sexual transmission, and there is minimal risk of empticity. The second category is suppressed but detectable, where the viral load is less than 1,000 copies. This may be because of missed doses, recent initiation within 6 months before virologic suppression is achieved, and very rarely resistance, particularly in the integrase era that we are really practicing. And here also there is almost 0 or negligible risk of sexual transmission. So this is enormous evidence from the systematic review to suggest that a viral load of less than 1,000 copies is almost a 0 risk of sexual transmission, and not just being undetectable, though your goal is to put everybody into an undetectable compartment. And finally, unsuppressed individuals are those with viral load more than 1,000 copies. Again, in the integrase situation, resistance is less likely, but can happen in the second line when you use it after a failure of your first line NNRTI-based regimen. But there is, of course, an increased risk of sexual transmission and empticity in this context. So this is an important graph and a cartoon here to show you the 3 viral load categories, the risk of sexual transmission, as well as individual consequences as far as ART management is concerned. And according to the WHO, amongst all the people living with HIV, most of the people are undetectable on ART. And as you see here, none of them transmit. Few people are on ART and suppressed, less than 1,000 copies. They are not transmitting the virus. And it's only on ART, unsuppressed or diagnosed and untreated or undiagnosed. It's majority of the transmissions of HIV that are happening globally today are of people who are undiagnosed with HIV. So test and treat becomes a very important concept. So the U is equal to U message now needs to be proactively communicated. This can tremendously help in reducing stigma and perhaps help us in channelizing and promoting ending AIDS by 2030. And finally, I will end up by showing you a very interesting study from China, which was the first randomized trial to look at circumcision and HIV transmission in men who have sex with men. In this, individuals were randomized into medical male circumcision and those who didn't have circumcision, and they were followed up. They had 116 person-years of follow-up. In the intervention arm, where circumcision was provided, there was no seroconversion, while in the control arm, there were 5 seroconversions with these 95% confidence interval. Now, this is something which needs further large trial, but would you really go for such a trial, particularly in high income settings, because PrEP is widely available there? And that is a better way of trying to perhaps reduce the risk of acquisition of HIV. But in areas where PrEP is not widely available, maybe this is an intervention which can help in reducing the incidence of HIV. So let me finish by acknowledging these sites which helped me to prepare this presentation, NATAP AIDS Map. And I would recommend all of you to visit NATAP because it's an excellent site which gives you the latest information on presentations across the world on various topics, HIV, HPV, HCV as well. And the IAS 2023 website as well for providing the abstract book. So thank you, and I will happy to take questions.
Thank you, Dr. Pujari. That was very informative. Let me get to the question straight off. So if you don't mind, I would like to ask a question of my own to begin with. For the Geneva patient, I think, when I was working in HIV, the Delta mutation was transferred because the HIV couldn't kind of latch on to the CCR5. What is the rationale for a stem cell transplant of wild type?
Yeah, so if you look at historically, the wild type transplants have all failed in the past, and this was the first interesting case where even the wild type transplant was able to prevent or putting somebody into remission. We really don't know the reason why this has happened. The investigators have done detailed analysis of trying to look at various compartments and showing that HIV doesn't exist there. And the main theory is graft versus host disease. So you're destroying all the host cells because of your graft, or it may be immune inhibitor, the ruxolitinib, which is a JAK2 inhibitor, which has in other study presented at the conference demonstrated to reduce HIV reservoir size. So maybe this is a combination of both, which may have led to a very anecdotal, surprising result in this patient.
Right. Yeah, and if we don't really know why that has happened, it's kind of useless as well. If we can't kind of replicate what has happened. Right. Okay. I'll get down to the questions asked by our audience. So in the dance study, which was conducted in adolescents, was the dose of the HIV or antiretrovirals tempered according to the body weight, or it was the same dose as?
Yeah, for DTG, I think I don't have that data, but for more than 25 kgs, 40 milligram of DTG is anyway recommended. 50 milligrams of DTG is anyway recommended, I guess. So I don't know that data. I need to check that.
Okay. So when TLD once a day was administered with rifampicin, do you know of any data where they checked for incidence of resistance in the participants?
There were, in this Radiant TB study, I presented that in the list of DTG mutations. In the Radiant TB, there was no resistance detected to DTG amongst virologic failure patients.
Okay. So instead of rifampicin and double dose of DTG, will rifabutin work, and how efficacious will it be? Your take on it?
Yeah, so first of all, we don't have very great data about randomized data about use of rifabutin for TB outcomes in HIV TB context, but we have been using it particularly along with boosted protease inhibitors. I don't think we need to adjust PK-wise the dose of DTG or rifabutin. When you can use those concomitantly, but the major problem with rifabutin in India is just not available.
Okay, right. And what about interaction between metformin and DTG? You think any dose?
So that was previously considered to be quite significant, and I think this has been settled. Metformin not more than 1 gram was what was supposed to be recommended when you use it with the DTG. But subsequently, it has been shown that hyperlactatemia, which was a major concern with metformin, doesn't happen. There were some observational studies from UK which demonstrated that it doesn't really happen. So perhaps I think it would be interesting to not use metformin more than 1 gram. In fact, there is a movement in diabetes world today to suggest that is it a death knell for metformin to be used in the diabetes per se because of the newer agent. So I think maybe carefully monitoring patients is what, and there are so many options available for managing diabetes.
Right. So if the viral load is not detected and the CD4 count is still dropping from 80 to 60 in a span of 3 months, what would you recommend the next step should be?
80 to 60?
Yeah, I mean, that's so much.
That may be a normal variation in your
Yeah.
CD4 measurement, so I'm not really sure. But if you have this drop in CD4 counts with virologic suppression, which is significant drop in CD4 counts, rule out HIV-2 infection if you have not ruled it out previously. And the patient is not on an integrase based, because integrase will work both for HIV-1 and 2. The second aspect is try to look for malignancy, lymphoma, or both non-Hodgkin's as well as Hodgkin's. This is because homing of lymphocytes happens towards the malignancy sites, and that is basically trafficking it away from the blood into the tissue, leading to a drop in the CD4 counts.
Okay. As per the WHO policy, U equals U, then is it advisable to go for PrEP in those who are aspiring for pregnancy and serodiscordant couples?
No need. No need. If viral load is undetectable twice over a 3 to 6 months period, you should proactively tell them not to use condoms.
Like, I'm curious, why proactively?
because it can improve the quality of life.
Okay, perfect. Yeah, I see. You're taking care of patients in holistic way, not only HIV. So, what is your opinion on an mRNA vaccine booster for those who have already completed 3 doses? So that's primary and the booster, I'm guessing, in people with HIV who have CD counts less than 200.
Well, with CD4 counts less than 200, there is a issue about immune response. But nevertheless, it is recommended normally. At present, we don't have any evidence to suggest that whether a 4th dose is required, particularly with what variants are circulating in the community, and whether your variants are being targeted, circulating variants are being targeted by the vaccine, one. Secondly, what should be the timing of the vaccine, whether it should be seasonal, at what point in time, whether you think when the epidemic is moving up again, when you are seeing some surges happening, whether you should do it before that. So unfortunately, at this point of time, we don't have clear data, though the Western world thinks that it's seasonal, particularly the US, and they are starting to already worry about trying to get the new bivalent vaccine for their populations by September, and they think September is already late.
Yeah. I think Moderna and Pfizer both have updated their vaccines to the new I think XBB variant. But I think one change what they've done is even the WHO and other guidelines, they have asked everyone to switch from bivalent to monovalent.
Yeah.
They've said that you don't need the Wuhan, so just kind of a monovalent. Because you can give more. You can give more of it. Bivalent, you have to split you have a limited dose.
Yeah.
So I think they're preparing for fall. They've already announced that they'll be launching it soon. So one question is, you appear to have mentioned that there was a study comparing a single dose DTG in TB treatment, assuming using a regimen with rifampicin as opposed to rifabutin, with twice daily DTG, and there was more or less equal efficacy in terms of viral suppression. Does it mean further studies are required to confirm?
Yeah, so this was a phase 2 study, and this looked at rifampicin with the TLD versus TLD plus one additional dose of dolutegravir. It was a placebo-controlled trial, and there was no difference in virologic suppression rates across these two. The second aspect is there are some observational studies also from Africa, which programmatically were using this because they didn't have an extra dose of dolutegravir. and they still reported good virologic suppression rates. So considering all this data, whether we should wait for a phase 3 trial, which is going to take at least 3-4 more years, or whether you want to roll it out and then do implementation research is what is the debate. The studies editorial in the journal discusses this very beautifully. So I can ask you to refer to that editorial to understand the implications of this in clinical practice.
I think this is even my curiosity. I think the last time last year we had done this, there was a lot of buzz about long-acting injectables or long-acting drugs and lenacapavir. Was there any presentations on those?
There were a lot of presentations on long-acting injectables, both for treatment as well as prevention. There was a lot of studies on real world. It was not just trials, about acceptability in the real world, about preferences, patient preferences, quality of life, challenges associated with rolling it out, etc., etc. There is a lot of data on lenacapavir, islatravir as well. Islatravir doravirine combination. The first randomized trial was presented by Eugen Rockström, which used a higher dose of islatravir, 0.75 milligrams. So they are looking at 0.25 milligrams now. I didn't present any of this data because they're just not available right now in our settings. And I hope this may be true even in some of the African and other lower and middle income settings. So when it becomes available, we'll certainly discuss this.
Okay. And just an estimate, when do you see long-acting reaching the Indian patients? Is it going to take a couple of years or?
Maybe you should tell us when.
Okay, yeah, I think Mr. Balaji, I'm going to ask him and get back to you about it. Again, your thoughts on a vaccine for HIV. I think last I checked, I think in US they've started a phase 1 based on whatever findings.
The new mRNA platform, they are now trying to roll it out, but of course it goes through all those phases. Up till now, all vaccine trials using viral vector formats and subunit combinations, etc., have terribly failed in HIV because in terms of eliciting broadly neutralizing antibodies, that is the key. That you need to induce broadly neutralizing antibodies. With the variation that you see in HIV, it's going to be a uphill task. So let's see if mRNA comes in. But right now, even in the absence of vaccine, we are talking about ending AIDS by 2030.
Do you think it's an achievable target, 2030, ending AIDS?
Well, right now, I think we have the tools and the science available. So we certainly know what scientifically works.
Yeah.
The only thing that needs to be done is social and political commitment.
Okay. Yeah, I mean, I think most of the endemic areas, maybe even Africa, if some tin pot dictator comes up, and then the whole thing is going to crash. So I think you're right. I mean, geopolitical and social will is more important than, as you said, the scientific. Right? In non-adherent patients on TLD treatment with multiple default and restart events, if viral load is low but not undetectable, then how should one proceed?
Yeah, so when you talk about low, I'm not sure what. I showed you 3 categories. So either it is about 1,000 or less than 1,000. If it is less than 1,000, you need to really work on adherence. And anyway, your genotypic resistance testing is not going to be very great at sequencing less than 1,000 copies. If it is more than 1,000 copies, and if you're really worried about resistance, you can check whether there is an integrase resistance, which fortunately, even in my practice, have been extremely rare. I've not seen DTG resistance, honestly. I don't remember seeing one. So in that context, you should have a look at the integrase mutations and then decide whether you want to work on adherence or shift the regimen. But more importantly, I think it is where you're using it. So if you're using it in the first line, it is highly unlikely that you'll have integrase mutations. But if you're using in second line, when you're transitioning from TLE to TLD, in the Nadia trial, there were some signals associated with DTG resistance. And that is where you should have a high index of suspicion.
So we are out of questions that are typed. I can get some people on if they want to ask questions directly over voice. So does anyone want to raise their hand? I can get them in. Sorry, no one's raising their hand, but I think I have another question. 2 drugs in HIV-2, someone has commented. I'm not sure what that means.
2 drugs in HIV-2, I don't think there's any data on that.
Okay.
At least I am not aware of it. But I think it should work, but I will not recommend it in practice.
Okay, this is a last question from me again. I think this is a little. I mean, you don't have to answer if it's a little unscientific. But I think recently the government is talking about doctors. They just have to write the drug name and not the brand name. Is that going to affect the way we treat patients in India?
I have not understood what is the recommendation, particularly in terms of ART. They have categorized drugs in general drugs into generic, branded, generic, and branded. These are the 3 categories. Even in the government program, they're using branded generics.
Right.
So how can they ask private practitioners to use generics when they are themselves using branded generics?
Right. Okay.
So I think for me, the argument is very simple.
Okay, so I think there's going to be a pushback, and the regulators are going to have to rethink what they have put out. Right? Okay, I think that's about it. I would like to. So firstly, Mr. Balaji and team, I think it's a wonderful tradition you have of getting the top speaker and making sure all of us are updated on what's happening in the world of HIV, and so that we can treat our patients better. I'd like to thank, of course, the audience for taking their time out and coming here, and the wonderful, insightful questions. And finally, of course, Dr. Sanjay Pujari, he's taken his time out and given us such a wonderful presentation for all of us. So on that note, thanks a lot, and have a good night, everyone. Bye-bye.